My name is Mr. Shafi Ahmed. I'm a consultant surgeon at the Royal London Hospital. I specialise in keyhole surgery and I'm the colorectal cancer lead for the Trust, which includes the Royal London, Barts, Whips and Newham. We've just finished the PLT meeting with the local GPs at Tower Hamlets, which I thought was really interesting, a fascinating experience about looking at cancer of the bowel and how we can improve things, and also to pass information on to the GPs about the work that we're doing at the Royal London Hospital, which is their local trust. Interestingly, what came out of this was the fact that the patients that referred through the 2-week wait pathway, only about 10% of the patients that are finally diagnosed with cancer actually come through this process. So the question that came up, of course, from the general practitioners was, how do we improve this process? How do we find other patients with cancer that don't come through this pathway? The other thing that I raised with them was the whole aspect of lung cancer, and a project done recently on looking at patients that present through the A&E department who have a primary diagnosis of cancer made on that admission. So these are patients that do not come through the 2-week pathway but present as an emergency. And interestingly, 25% of patients with bowel cancer present with obstruction or perforation requiring emergency operation, or indeed present quite late with metastasis that ultimately require palliative care. So if you take away those patients and also the 2-week referrals, that leaves a proportion of patients that come through screening. We have sort of two processes in place at the moment. The bowel cancer screening at the moment is for patients aged between 60 and 69 who have a 2-yearly fecal occult blood test. And that again brings about 10 to 20% of patients with cancer diagnosis. The screening service will change. There's been a pilot being performed currently and last year in various parts of the country looking at 1-stage flexible sigmoidoscopy between the ages of 55 and 64. And this will greatly improve the detection of cancer, but also it will reduce the mortality and ultimately produce cancers at an earlier stage. We have a unique problem in Tower Hamlets, of course, that we're all aware of, that patients present quite late, and we have probably one of the highest mortality rates in the country. Not just the country, of course, the mortality rate for colorectal cancer across Europe, we have one of the highest mortality rates. So we are fighting this with a view to how do we improve the service. The other thing that came out of, I think, the conversations we had today with the GPs, which was very useful, is the communication and how we improve that communication with patients going down a cancer pathway. This means that we must ensure that we have MDT letters and outcomes from the 2-week process sent back to GPs quickly and efficiently. And certainly I'll take that back to my team at the London to ensure that we improve our process. One of the interesting things that our cancer lead for Tower Hamlets in the general practice, Dr. Tanya Anastasiadis, has raised is that we could improve the communication, which we'll try to address at best, but also some of the key information parameters that are required in the feedback. For example, staging of the disease in terms of stage 1 to stage 4, so they can actually look at the data more prospectively and interrogate it so that we can do some good work and feedback to the GPs who may reflect on the reasons why the cancer was not diagnosed early enough, for example, what they can do to improve their own clinical pathways. Thank you.
I'm Dr. Lisa Das, a community consultant gastroenterologist, and also sit on the upper GI and lower GI MDTs at the Royal London Hospital. So we've just had a GP PLT which was entitled the Cross-Specialty Review to Improve the Diagnosis and Outcomes in Gastrointestinal Disease, which involved both myself, consultant gastroenterologist, and Mr. Shafi Ahmed, consultant surgeon, as well as some of our trainees. We covered initially the topic of a one-stop dyspepsia clinic, which is a new pilot due to be taken out on the 2nd of April, which received good response, I think, from the GPs, and we will finalise the referral form for that, which will enable better access to a one-stop shop clinic, which will allow endoscopy and ultrasound scan with a follow-up consultation all in the same day, with a report to be taken back to the GP, which will minimise delays and waits for the patient and hopefully give the GPs a better management plan. We then covered H. pylori update, which since 2012 has changed quite significantly in that we were initially talking about 7-day test and treat triple therapy, which is no longer valid given our increasing rates of clarithromycin and metronidazole resistance. We've discussed the new pathways, which are that of sequential therapy, concomitant therapy and hybrid therapy, covering a 10 to 14-day course, and this has been outlined in the discussion. New information was received quite well. There was a lot of information to disseminate, and probably more so that we can get some local geographical input from the pharmacists and the local prescribing teams to ensure that this is applicable, and most importantly, proving eradication at the end of therapy is also to be recommended currently. We discussed BowelScope, which is a new upcoming flexible sigmoidoscopy screening program, which has been covered by Mr. Ahmed also. We're hoping to roll that out in 2015 as a one-off flexible sigmoidoscopy. And Judith Shankelman, a public health strategist, also covered the increasing uptake, which is historically poor in Tower Hamlets, of the bowel cancer screening program. And we've had some funds put in for intervention at the GP surgery level, because this has been shown to improve uptake since Tower Hamlets is in the lowest quartile of the country in FOBT uptake. With this intervention, accessing the GP records so that there was endorsement from the GP, we have improved our uptake rates by approximately 5 to 15%. This is still short of the national uptake, but we're hoping to achieve this with additional information which is locally available as an enhanced service.